I'm supposed to be talking to you about counseling when we talk to a patient about improving an abnormal limb. Not too sure what exactly this entails, but here goes. Which kind of conditions which I would think qualify for this definition of improving an abnormal limb, not making it absolutely normal, improving. Something like an Elizarov hip reconstruction in a septic hip, something like tibial lengthening in hemimelia, or healing a non-union with soft tissue damage. All of these things, they help, they improve the limb, but don't make it normal. You already heard about what is needed for any counseling session. I think you need to have empathy with the patient. You need to be pragmatic in terms of what solutions you can offer in terms of your infrastructure, what the patient can afford, etc. And you need to be honest with the patient what the future holds in terms of the results, what your own abilities are. And to me, the most demanding patient is actually one of the best, because that kind of patient forces you to re-examine your own thought process. The patient wants to have his cake and eat it too, and you think that's not possible. But when your patient asks you, sometimes you sit down and think, rethink your thought process. What are the treatment abilities or options you have? And that is one way of continuous self-improvement, getting really demanding patients. I like to get patients to define priorities. So if when they have a shopping list of problems, I will tell them something like, if I say that I can solve only one of your problems, which is that problem? So they, of course, they say, I want, everything, but I say, no, one. And that kind of gives you an idea of, okay, what is the thing that is troubling the patient most? We should remember that we should give the patient really what the patient needs and not what you are good at. For example, if a patient really needs an Elizarov and you don't do Elizarov, then it's probably a disservice if you try and offer them something which is, related to internal fixation. And whenever I speak to a patient, I try to lay out all of the options. Patients ask for guarantees. Of course, we can't give guarantee. What I guarantee them is 100% of the effort. I give them an example of, my job is to take you from here to Delhi. If everything goes well, we'll go on the highway. If we get barricades in the way, I will have to take you, through side routes, etc., and get you there. But you should give them a reasonable assurance of what outcome they can expect. Informed consent, I think, at least to me, informed consent depends on how you are biased, and you draw that bias into telling the patient the results of whatever procedure. I would normally go something to the effect that, okay, these are the options. I think this is what is good for you for such and such reasons. Also, lay out all of the stages, if multiple stages are required, multiple time periods are required, what the costs will be. And I think there is hardly anything where you need to rush a patient. I will always be happy to give the patient the option for second opinions, give them a couple of good names who I think are good for that particular problem, and give them the option to come back with queries and decisions. With that, I found usually patients are satisfied. I get to sleep well at night. Thank you.